Yes, Dr. Yalai.
You're live. Okay. Good evening to one and all. Um, from the Indian Society of Parental Enteral Nutrition, and we are really delighted to have you all over here for this so apt webinar on sarcopenia and critically ill. And this is also the time that we've had the first four candidates of ours who've actually joined the first fellowship in critical care nutrition, which is the ISPEN ISCCM combined, and we congratulate all four of them for having taken up this field, one of the kind course, which is at this moment held at two hospitals in the country. And to take us further with sarcopenia and critical ill, which is such an important topic, we have extremely good four speakers who are going to lead us in this. The first is Mrs. Ramya. She's a head and senior clinical dietitian at the Apollo Specialty Hospitals at Vanagram, Chennai. Welcome, Ramya, to this panel discussion.
Thank you, doctor.
Second one is Mrs. Chitra Mahesh. She's the head dietitian at Meenakshi Multi-Speciality Hospital and one of the very old members of the Indian Society of Parental Enteral Nutrition. Welcome, Chitra, to this panel discussion. Um, the third is Dr. A.J. Emma Malini. She is a professor and head Department of Clinical Nutrition at Sri Ramchandra Faculty of Allied Health Sciences and the Institute of Higher Education and Research. And I'm very happy to have her on board, and we'll learn quite a bit of things from Hema Malini too. Thank you, Dr. Hema Malini, for making your presence in this particular webinar. And last but not the least, the person who's organized this particular webinar, Daphne Lovesley, who is the Chief Clinical Dietitian of the Apollo Main Cluster 1 at Chennai. And she's the Director of Clinical Nutrition and Dietetics, the internship program too. Welcome, Daphne, to this webinar. And I am definitely going to learn a lot from all of you people.
Thank you, Dr. Sanjit.
You're welcome. So we are going to for the purpose of housekeeping, I would request whoever wants to ask questions to please just put it in the chat. I will try to address each of those at the later date. And as the conversation goes, you can definitely keep asking questions, and we will take those questions at the given whenever there is the opportunity to do that. So first of all, I would want to first ask Ramya. Ramya, do you think that sarcopenia is something that we should be worried about in clinical practice? And if it is so, if you are really worried about it in clinical practice, why do you think we should be worried about sarcopenia?
Yes, doctor. So over the past few decades, we have seen a progressive increase in the number of geriatric admissions to the ICUs. In addition to that, there is also an increase in the chronic diseases at patients with chronic diseases. So most of these patients present to the ICU in a malnourished state, and and also their activity levels are quite low. So they normally have massive loss of muscle mass, and or this could lead to reduction in the muscle function also. And so, as you said, sarcopenia will be present in almost many of these studies. Rather, have shown that almost 30 to 70% of the patients who get admitted to the ICU are sarcopenic. So this is a very big number. So it will, and this is going to have a very poor prognosis for these patients. So why? Because these patients normally they, because of the muscle mass loss, their respiratory muscles are normally in a weak state. As a result of which, it is going to be difficult to wean them from the ventilators. So this is going to prolong the length of stay in the ICUs as well as in the hospital. In addition to that, they also develop insulin resistance. So this is again an important factor which is going to have an impact on the morbidity and mortality. So, and many of these studies have also shown that the mortality is almost double fold in the sarcopenic patients when compared to the non-sarcopenic patients. So, it is very important to treat this sarcopenia. First of all, it is important to screen and identify these patients so that they can be treated to improve their clinical outcomes.
Right. So I do understand, Ramya, that sarcopenic patients do have higher degree of morbidity, and you also said a higher amount of them would die eventually when they are admitted for critical illness. But Chitra, I would want to know from you that what exactly is the cause that sarcopenic patients actually have higher morbidity? I mean, what exactly would be the cause? Is it immune related? Is it related to just they develop an infection quickly, or what exactly is the cause that actually makes sarcopenic patients vulnerable to an extent that they either they die quickly or they get some morbidity? What do you think is the cause in your experience, and what do you feel is the
Uh,
cause?
as Ramya said, it's not, see, so even in my practice, I see a lot of geriatric patients. Many of them come in with sarcopenia, which is multifactorial. So that is a combination of both primary sarcopenia and secondary sarcopenia. Or after they get admitted in the ICU without proper nutrition or um, lack of exercise, they develop something similar to secondary sarcopenia called the ICU acquired weakness. So where there is weakness in both the limbs and respiratory muscles go weak, all this, and there is insulin resistance, inflammation pathways are activated. All these lead to increased morbidity, and when not treated may also become increased length of hospital ICU stay, increased length, increased days on the ventilator, and if not treated, then it can result in mortality.
Right. So
I think Dr. Sanjit is. So there is a question. What tool do you use to diagnose sarcopenia in bedridden patients? So before going on to the tools, maybe we should first understand, what is sarcopenia, because there are so many definitions available. And historically, when you look at, the literature, they say sarcopenia relates to loss of muscle mass. But over a period of time, there has been a lot of researches happening, and a lot of, European and Asian working groups on sarcopenia, especially relating to elderly. They came up with a lot of definitions, which included not only loss of muscle mass, but loss of muscle strength and loss of muscle function. So three components. And when we look at the European Working Group definition as such, there was a shift from muscle mass to muscle strength, because muscle strength assessment becomes a little easier, and it tend to, become prominent quite early, before even the loss could happen. There is loss of strength. So what the Asian population or the South Asian Working Group, how they define it is, if in case we have two of the losses, either a loss of muscle mass or a loss of muscle strength or function, any of the two, if it is present, then you confirm that they are sarcopenic. So screening, as Ramya said, is very, very important, because unless we screen it, we don't even understand whether they are at risk of sarcopenia. And we did discuss that, there is muscle wasting in, critically ill patients, and you should understand every day they lose about 2% of skeletal muscle mass in the first week of admission. So as dietitians and clinicians, we should be aware of this, and screening these patients are quite important, But it is a very difficult task, I tell you, because most of them who are ventilated, it becomes a task for us to assess them or screen them. There are some of the tools which are available. Maybe if they are non-ventilated, it might come in little handy, like SARC-F, SARCF. It's nothing but the strength of the person, whether they are able to walk without assistance, whether they are able to raise from the chair, and they are able to climb the stairs, and whether they had any fall during the last few months. All these can be collected to understand. Higher the score, lower their muscle mass. This could be a good screening tool for people who are not ventilated, because this has to be discussed with the patient. And if the drawback of this tool is that it is not highly sensitive. So what else can be done? Maybe we can think of hand grip strength. It's a very simple tool for people who are non-ventilated, and the cutoff varies a lot. Globally, if you see, the cutoff is quite higher, but Indian setting, we do have some standards, less than 27.5 for men and less than 18 for women. That's a consensus statement that is in as part of literature. And as dietitians, I can tell you, we can do a little bit of anthropometric measures. That also comes in very handy to screen them. It can be a mid-arm muscle circumference or a calf circumference. Calf circumference is, really gaining a lot of importance of late, especially in critically ill patients, even both ventilated and non-ventilated. You can do a calf circumference in order to screen the patient. And you can ask me, if in case they are obese, how do we handle? Because there can be a cutoff. We need to have a cutoff for healthy people and for obese people. For obese people, if their calf circumference, from the calf circumference, you need to reduce -3 centimeter if they are between 25 to 29 BMI. If it is between 30 to 39, you need to subtract about 7 centimeter. And if it is above 40, you need to subtract about 12 centimeter of the calf circumference. Then you should, categorize it as moderate or severe. If in case their levels are less than 34 for men and less than 33 for women, it is moderate, muscle mass loss. In case of severe, it is about 32 and 31 for men and women respectively. This is a simple tool which can be used in, critical setting. If a person, is in end stage disease, generally we see the physical therapist making them walk around, right? 4 meter or 6 meter walk test. That also help us to understand the frailty of the person. That is also very important, because that's a functional measure that can be looked at. Yes, Dr. Sanjit, you can continue.
It's fantastic that we can actually do simple things like anthropometry just to understand sarcopenia. But there was a small question in the chat box that they are saying that they are doing mid-arm circumferences and calf circumferences, but they're saying sometimes the muscle appears weak. So when they appear weak, how do you actually, they're looking weak, they're hanging, they're very loose. At that time, how do you actually say that this is the mid-arm circumference, or what is the mid-arm circumference? Should it be tightened up, or should it be loosened up when you're actually using the tape measure when the muscles are loose?
No, usually it is advised not to tighten or loosen. No, it should be done. Yeah, it should not be.
Yeah, so there's also a question that talks about what happens to a bedridden patient and how do you actually understand sarcopenia in a bedridden individual. So what is your take on that?
Maybe you can, go for better tools like ultrasound, because as a dietitian, I may not be, able to do that. Clinicians should pitch in to help us understand the muscle mass, but many times in busy centers, it is very difficult to take the help of clinicians to do, ultrasound of muscle, or, thinking about diagnostic tools like MRI, CT. That doesn't happen on a routine, right? That is why we think of simple tools which can be done on a day-to-day practice. That is very, very important as a dietitian to understand whether the patient is sarcopenic or not.
Right. So when we say sarcopenia now, there's a whole push towards going away from muscle mass towards strength. I mean, we are going from muscle mass towards strength, and strength and physical function is what is getting more relevant as compared to muscle mass. So if
Exactly.
somebody would actually look at bedridden patients, one of the things that you could also do if your center does have the provision to do that is to actually look at the bioelectrical impedance analysis, a tool that you could use to actually figure out the appendicular skeletal muscle index. Something that can be, of course, this is something that also needs to be validated in Indian scenario, though we have South Asian cutoffs, we don't have Indian cutoffs. Importantly, the cutoffs that Daphne you mentioned about 28 and 17, the cutoffs that you mentioned, this is from the Chandigarh study. Is this from the Chandigarh study that we talk
Yeah,
about?
Indian data.
It's the Indian
But
data.
it is from Indian data, but I can tell you the population wise, specific to diseases also there is variation. Say, for example, I have done a study where, I looked at the pre-transplant or the baseline transplant patients, pre-transplant evaluation. I found that a cutoff of less than 20 had an impact on their 1 year post-transplant survival. So it varies. So in general, maybe we can take it as 27.5 and 18, but there are in cirrhotic population, I do find studies saying less than 17.5, it had an impact. So it really varies.
Yeah, is Hema Mani here on online now? Is Hema Mani here?
Yeah, she's there.
So, Dr. Hema Mani, are you there around? Can you hear me?
Yes, I'm here.
Yeah,
Can you hear me?
yeah. So I was just wondering, there is a very important criteria that we talk about called as the SARC-F criteria when we look at sarcopenia. Are you using this do you recommend using the SARC-F criteria at least to screen out a patient of sarcopenia before we actually go ahead and figure out muscle function and muscle strength? Do you think that we should use the SARC-F criteria, which the European societies have actually asked to be used? Do you think we should use that? Or Chitra, can you take this talk? Chitra, are you there? If
Yeah, I'm
Hema
there.
Malini-
Yeah. So I feel SARCF is more for outpatient practice.
And can you? I could not actually.
Oh, Hema? So SARCF is more for outpatient practice, and it may not be possible in critically ill patients, which is the topic of the day. And we can, however, rely on nutrition-focused physical exam (NFPE), which is more useful in.
Yeah. So here again, when we actually talked about muscle strength, Daphne did mention about hand grip being a very inexpensive tool that can be used, and the number cutoff that we got from an Indian study that says there is a cutoff for hand grip. But the question, as Chitra said, is for hand grip, you need the person to be sitting on a chair at 47 degrees, 47 inches high, with the leg on the floor, and these are things that you generally cannot do in a critically ill patients generally. So again, we don't have that real cutoff that would actually look at hand grip. So at the end of the day, yes, Chitra, is there something you
Yeah,
want to
but the
add in?
patient can be his own control. So if you're going to
Yeah.
have all these done on the day one, and you can do it 2 or 3 days later, and he can be his own control to see whether the
Yeah.
muscle
Yeah,
strength or
you're right in telling the fact that if the you can actually look at it, but on a diagnostic kind of scenario, it definitely, I think you should still rely on things
some
that we can
difference.
from history and things like that is what it looks like. So what I understand is even the classical sit up sit down test that we can, which is so good when it comes to sudden burst of energy in these patients, ergogenic exercises that we talk about. These are also things that can be done. However, in the critically ill patients, this all becomes a big problem when it comes to sarcopenia. So, Daphne, Chitra, what do you think are the various techniques now that you say you have sarcopenia? You have a patient who has sarcopenia. You decide they have sarcopenia. You put the GLIM criteria and you find them to be moderately malnourished on that feature too. What are the various techniques that you would use to combat sarcopenia in your usual practice? Okay, in your hospital, what would you do to combat? For that matter, you said you monitor them. You can monitor them on a regular basis to figure out. So how do you modify your practice the moment you get a sarcopenic patient? Let's take two patients, one patient who's not sarcopenic and the other patient that is kind of sarcopenic. What would be the different things that you would do, very different from what otherwise you would do for a normal patient? Yeah.
Okay, so first let's understand there is no standard treatment protocol for sarcopenia in critically ill patients. However, the usual treatment approaches like exercise and nutritional therapy, like how it helps in other population, works good for these sarcopenic patients too. So I'm not going to talk much about exercises, though early mobilization in critically ill is very crucial for prevention of sarcopenia um, uh, or um, um, or treating sarcopenia. When it comes to nutritional support, definitely adequate proteins with a good amount of essential amino acids is given. And I look at some deficiencies like vitamin D or calcium if they have any. If there are any deficiencies, then it needs to be treated. I do not believe in giving overdoses or mega doses of any of these nutrients. One nutrient I would like to rely upon now in these recent past is beta hydroxymethyl butyrate, which, when given along with other essential amino acids and adequate amount of proteins, works wonders. It helps in both gain of muscle mass and helps in improving muscle function. And beyond that, if I look at if I want to see whether continuous feeding favors or interrupted feeding favors, though there are some studies that show interrupted feedings favor muscle protein synthesis in critical illness for better glucose control and fluid balance, I favor continuous feedings over interrupted. Probably you could I will start with continuous feedings and then move on to interrupted feedings at a later date. Depending on what kind of protein powder I would choose, I know there are many scientific formulas with a blend of with protein from a blend of different sources. It is okay, but what I personally feel is I won't go in with albumin powders because they are lacking in essential amino acids. I would rather go in with formulas that have HMB added to them when possible. And when I'm not able to make up the protein to reach my target, then I add in some soluble protein formulas to the chosen formula. So that is one point. And another point is how do I give the proteins? Do I give it all in one go? Definitely no. Like how we step up the calories in the acute phase of critical illness, we need to also step up the proteins. So probably day 1, I start at 0.6 grams. Day 2, I move to 0.8. Day 3, 1, and then 1.2. I aim for 1.5 grams per kg body weight. And another thing I would like to say is in respect to patients with acute kidney injury going on CKD or patients with chronic kidney disease. As is done in outpatient practice, I do not believe in limiting the proteins for these individuals. So as ISPEN and ISPEN guidelines say, that we should not restrict proteins just to delay or avoid renal replacement therapy. So adequate, I aim for at least 0.8 to 1 gram of proteins per kg in case they're not in RRT yet, and maybe a little higher when they are started on RRT. And what else would I look at? Okay, does the route of feeding favor muscle protein synthesis? Yes, some studies say that parenteral nutrition supports muscle gain, but again, it does not, improve the muscle fibers, it only increases the fat content of the muscle. So always for me, enteral nutrition is the first choice. Only when there's some kind of contraindication, then I go in for parenteral nutrition. So these are the
Correct.
various
Yeah.
things I would look at.
So I would be asking the next question to Khalid, and subsequently the next question would come to Hemamali right after Dr. Khalid. Dr. Khalid, welcome to the webinar here. So we are in the middle of a discussion, and Khalid is from the ISPEN Pune. The next conference is going to be the mega conference that we have for ISPEN is going to be at Pune, and I'm certain Dr. Khalid will play a very important part in that particular conference in the month of November. So, Dr. Khalid, we're actually in the middle of a very intelligent discussion on sarcopenia and in critically ill. So what is your take as how are you mitigating sarcopenia in the critically ill patient that gets admitted? Say, let's take an example of a patient who comes in with severe illness, who's on septic shock and he's on mechanical ventilation. How are you? What are the few, if I say four things that you would probably do in this patient, to four things that you would do in this patient, which will be different from other patients to mitigate sarcopenia?
Yeah, thank you, Dr. Sanjit. I think sarcopenia per se is very important in the sense that it affects our patient's well-being. Patients who are sarcopenic when compared to those who are not sarcopenic, when they come to the critically ill or when they come to the ICU, when they become critically ill, it is important that sarcopenia will affect their ICU stay. So the other point is patients who come to the ICU without sarcopenia and those who develop sarcopenia in the ICU associated weakness, what we call, or ICU associated polyneuropathy or myoneuropathy. So these patients they are going to be worse off just because of their sarcopenia, irrespective of what disease they have come with. So it is very important to diagnose whether they are sarcopenic when they get the critical illness. And the second part is that we should also try and mitigate that they do not worsen their sarcopenia or they do not develop sarcopenia for patients who do not have that. So how do we do that? So when they are critically ill, say in septic shock, at that period, I think we are just trying to save them by giving them lots of vasopressors, treating them, giving antibiotics. But it is after 24 to 48 hours when we have now stabilized the patient on whatever dose of vasopressors are there, whether he is on ventilator. Depending on that, now we are going to think, once we have got him out of the life-threatening situation, we are going to think now, what do we do to prevent him or get him better well? So prevent his worsening of the sarcopenia, which will have effect on his outcome. So what do we do? So now we are going to think of how much calories to give. So we do not want to give him too much calories in the initial period. How much protein we want to give. All those things we'll start thinking at this period. And once we have decided that he needs treatment, he needs to be nutritionally supplemented. That is the time when we are going to think about how much protein to give. We want to build up his protein within the first 3-4 days so that we are giving him around 1.2 to up to 2 grams per day, 2 grams per kg per day. So, and calories will slowly build up within the 3 to 4 days, so that initially we are hypocaloric and then we give him maybe isocaloric or we get him up to the mark. So we are going to give him adequate proteins and take care of his calories so that he does not at least worsen his sarcopenia, or if he doesn't have sarcopenia, he does not develop sarcopenia. Dr.
Fantastic.
Sanjeev.
Fantastic. So, I mean, what Dr. Khalid says is what echoes from every consultant's mind, that sarcopenia is a problem. People die because of sarcopenia rather than the disease itself, and it's important to try to combat that aggressively right from the time that the patient is admitted. So, Dr. Hemamali, is there something that you would do different in these patients? And we'll come to a couple of questions. There are a lot of questions that are come in the chat box. But what I'll do is I'll first ask Dr. Hemamali as to what are you doing separately. So we heard Daphne saying that she would diagnose them by looking at a hand grip or maybe a clinical estimate or looking at how the patient is or a recall or things like that. We heard Chitra talking about the fact that she would probably add a little bit of HMB and slowly build up the proteins. We saw Dr. Khalid saying that he would be very much passionate upon quickly going into calories and proteins and building it up to even 2 grams per kilogram is what Dr. Khalid said. Dr. Hemamali, is there something else that you would probably do, or would you probably have the same kind of protocol?
Yeah, of course. It is almost similar what has been discussed with respect to appropriate assessment, and then of course starting with the appropriate nutritional intervention. We were talking about two components, which is like Ms. Chitra said that we would want to give a good energy, while Dr. Khalid was talking about not to feed them, overfeeding also to be avoided, because excessive energy, if excessive high calorie, if you plan to meet, what happens is that thing called as sarco obesity which occurs. Why we are talking about sarcopenia, and overwhelmingly if I feed with excessive calories, I may result or I may require to handle even the sarco obesity. That is what something that we need to look at. Having said that, the energy can be anything. Like in a critically ill patient, we normally look at energy which is something 20 to 25 kilocalories. So same thing we can start up with as far as even these sarcopenic patients are concerned, avoiding overfeeding. And protein, most of the articles recently published, theory says that we can continue to give at 1.5 grams per kg body weight. Whether I know I want to go up to 2 grams is probably matter of concern, and at the same time with more with respect to the patient, individualized patient estimations that can be considered. So that is the second thing I wanted to tell. But at least anything up to 1.5 is being basically recommended, and I could see here in the comment box something like 1.4 cals and zero point 0.6 grams per kg per day. So that tells like we have to avoid overfeeding. And in addition to what was discussed regarding the protein source, because again there is a lot of role played for the branched chain amino acids and also the whey protein. Both these sources of protein seem to have been given a positive result in attenuating the muscle loss. So, so this is the next one.
All right. Yeah, so it appears that there's some we've lost a connection, but I'll be asking the next question to Daphne and then follow that up with
Oh, I'll
uh,
just finish what she was just talking. When we
yeah,
talk
sure,
about
sure.
branch chain amino acids, maybe we should think of 0.25 grams per kg body weight of branch chain amino acid, which might help in arresting muscle depletion and, take it forward with protein synthesis. And one more thing I wanted to touch upon is if in case somebody is severely sarcopenic, we should be very careful while initiating feeding. We should always think about refeeding also. So refeeding syndrome will become an issue when we talk about critically ill sarcopenic. So start slow, go slow, gradually step up while monitoring all the electrolyte parameters.
Correct. So what is very clear is that we go slow, and in critically ill patient compared to another sarcopenic patient, there is always a very high risk of going into this menace of refeeding syndrome, which can be quite disastrous. We might not even realize that the patient is going bad because of refeeding, and it's not really related to the general condition itself. It will be just refeeding syndrome causing it. So there's a very interesting question that's come in the chat box, and I'm going to ask Daphne this question, then follow that up with Chitra and Khalid's ideas about that too. So we as intensive care doctors are now we are mobilizing our patients quicker. We are trying to do a lot of things with respect to their physical rehabilitation very early on in the disease, very early on in the disease. So we've moved from patients, we start moving patients on the ventilator also. We make them move on the ventilator also. So when it comes to physical rehabilitation, which is actually one part of the entire story. I mean, diet is one part, but the very important part also that we also have equal importance is physical rehabilitation. So when we look at physical rehabilitations, there's a question that comes is what is the physical rehabilitation when we talk about? Can you opine on what kind of physical rehabilitation are we looking at? Are we looking at resistance-based exercises like TheraBand exercises on a bed-bound patient? Are we looking at ergometric exercises like cycle ergometers? Are we looking at just mobilizing the patient to a chair, or are we looking at proper passive physiotherapy or aggressive active and passive physiotherapy? What are we looking at when we look at for sarcopenic patients in order to improve muscle mass? Daphne.
Even moving them out of bed is the first step that they do. You know, even that many ICUs they do not do. These are things which have to be done at the earliest. moving them out of bed, maybe cycling. There are so many institutions where, in dialysis centers and all, where people may be very sarcopenic, they do a lot of cycling. And in critical setting, as they improve, this can be a part of it. Especially when you talk about, patients on ECMO, we do have therapists doing these cycles for them. They are connected to ECMO, but they will be doing all these exercises so that they improve on their muscles. So the early they start on these exercise programs, the better. And one more thing is about the chest physio. That also will be a regular routine that they will be doing.
Khalid, what Dr. Dabney says is that, we are not moving patients out of the bed. Do you agree to this? That how is it? How do you think in Pune it is? In Pune, do you think patients are moved out of the bed quickly or not? I mean, this is something very important, very essential, because
It's
if you
across, it's not for anybody in particular. There
no, no,
are
no. I get your point. I get your point.
regions.
But it looks like that is what is going on across. So we'd like to put this point very clear to whoever's listening to
Very
this
true.
webinar that movement is important. But Khalid, what is your take on movement? Is there what is it in Pune? In Pune, do people move them out of the bed? What is it?
Yeah, I totally agree with what Daphne is saying, but I think one should look at it both ways. So you have a patient who's critically ill who has landed in the ICU. If you look at our patients, they are not only having sarcopenia, they are sarcopenic obesity. And this person is not moving at all in his routine life. And he comes to the ICU, say, with myocardial infarction, or he's on the ventilator. And now we are saying that we should start moving him. I think that becomes a little. So we have to assess the patient, how the patient is, what was his pre-morbid mobility. And I totally agree that we must start early mobilization. What you are saying is totally correct. But for somebody who has not been moving, and if you now, when he is critically ill, now we decide that he needs to be moving rapidly, or he needs to start doing cycling, ergotherapy, or whatever we decide he needs. I think we need to take it with a pinch of salt for our patients. Of course, they need something is better than nothing. That's I agree with what all everybody is saying. But I think we have to be a little conservative because our patients generally are not that mobile. So if somebody is
Yeah.
athletic and he is critically ill, I don't mind getting him, immediately off the bed even when he is connected to the ventilator. But generally for our patients, I think we may be a little more conservative. But of course, some or the other physiotherapy we are giving them. It's not as if they are just lying on the ventilator and not doing anything. But how much is too much for our patients? I think we need to be a little conservative. That's my
You,
take on that.
You're absolutely right on that. In fact, it's quite dangerous to actually do a lot of things aggressively in the intensive care unit, and we've learned over a period of years that the nursing pattern, the nurse per patient ratio, the doctor patient ratio, they all matter a lot when it comes to mobilization. Because if you have to mobilize a patient from the bed onto the chair, we really require a lot of manpower and somebody who can also observe the patient all the
Yeah.
time, because most of these patients do develop postural hypotension, because these are those critically ill patients who may go down. They are connected to drips and they're connected to wires, and this is a very dangerous thing because it might just flip out these wires and tubes from the patient. So it is a problem, no doubt. But yes, all said and done, we think that we should mobilize them as much as possible. In fact, we've just in our ICU just started a harness mobilization device. We just bought one so that we could mobilize these patients on the ventilator too. Chitra, there is one delegate who's asked, Diksha, her name is. She's asking whether we give very low calories to begin with, and she's basically mentioned if the BMI. She's looking at BMI. I mean, BMI is also not a very bad surrogate when it comes to sarcopenia. We know sarcopenia BMI less than 14 is really really bad. So at less than 14, should we give very low calories, and what is low? So she's mentioned it as, should it be 10 to 14 kilocalories per, or it should be 0.6 gram per kilogram per day of protein. So what will the number be? Matlab, if you have to choose a number, what will be the number in this severely sarcopenic patient? What would be the number? You please have to unmute yourself.
In severely sarcopenic patients whose BMI is less than 14, we definitely need to be careful both with calories and proteins. Calories, yes, we can start at 5 calories per kg per day and step it up gradually over the next few days. This is mainly to avoid refeeding syndrome and, of course, overfeeding. And similarly, proteins also need to be started at a very low rate. I said I would start with zero point 0.6, but with the BMI as low as this, first let her differentiate whether it between sarcopenia and cachexia. Ask her to check whether it is sarcopenia or cachexia. Uh, so in a situation like this, you can probably start at 0.4 or 0.5 grams of proteins per kg, and then gradually over the next 2 days, you can increase by 0.1 or 0.2 grams, and then gradually step up. Anyways, the protein delivery has to be progressive.
Yeah. So what we do know from at least the latest data that comes in the Nutria 2 and 3 trials that came in, it was the fact that you can go as low as 0.2 grams, 0.2 grams per kilograms when it comes to extremely low BMI, or for that matter, even 0.2 to 0.6 is equivalent to 1.2 grams per kilogram for the first 7 days is what is very clear from the Nutria 2 and 3 trials that came out recently. There is two questions that have come in the chat box, and they're saying whether we should take care of any other nutrients when it comes to treating sarcopenia, and any comments on vitamin D. Dr. Emma Malini, is there any comment on vitamin D here, and anything with respect to any other nutrients that you would consider in the treatment of sarcopenia? We heard about HMB. We did hear about macronutrients like proteins and calories that we talked about. Is there anything more apart from this that you would look at? Is the question. I mean, there's vitamin D also being asked over there. Yeah. You need to unmute yourself. Please unmute yourself, Dr. Hemamani. Please unmute yourself. Yeah.
So we were talking about even omega-3 fatty acids to answer that question, where other nutrients. And vitamin D, there are a lot of reports to say that vitamin D also is very, very helpful in attenuating the muscle loss in case of sarcopenia. And along with that, definitely the calcium goes in. So these two are very important nutrients. At least at the rate of 400 IU is what has been recommended in many of the studies as far as vitamin D is concerned. Apart from that, since there is a lot of mitochondrial dysfunction that is involved in sarcopenia, vitamin B complex also has been highlighted. Vitamin B1, B6, all this whole lot of vitamin B complex is something what we need to give importance to. And there is so much of inflammation and antioxidative stress, sorry, oxidative stress because of the building up of the ROS in the mitochondrial dysfunction. There is also recommendation to talk about most of the micronutrients, vitamin E, selenium, zinc, all this magnesium, all these also have been highlighted, which has to be given along with the other macronutrients that we were talking about.
Yeah.
So we
So
definitely, vitamin D, a lot of literature is there to support vitamin D supplementation as
So
well.
the only thing when we come back to evidence-based medicine is something that somebody's mentioned on the chat box, is the fact that as of now, though we know that vitamin D is something logically that we want to use, however, the evidence for the treatment of sarcopenia at this moment in intensive care unit is not very strong as of now. However, when it comes to out of intensive care unit, yes, vitamin D does seem to have a role. There are two designer proteins that probably comes to my mind whenever we talk about sarcopenia, and one of them is creatine. So I was thinking whether any of y'all are actually, so as in the when you go to the gym, when you go to a normal gym and you see abroad, or for that matter for any other place, you would probably have people having creatine, which is a fantastic molecule that prevents ergogenic failure. I mean, it's one of the few molecules that prevents, one of those few things that prevents ergogenic failure. So, looking at that, is there any experience in this group of the use of creatine for muscle mass buildup in ICU? And for that matter, one of the big studies that actually had a four-prong study was HMB, creatine, and arginine. So, these were the three combinations that were used to mitigate sarcopenia. So, is there anyone who's practicing this kind of nutrient over here? Daphne, are you doing something like this?
We do give creatine in patients, especially in our ECMO unit, where patients are put on ECMO. We have a protocol where we give creatine as part of, nutrition. So around 1.5 to 2 grams per day is the prescription that goes. So,
Okay.
and it really had a difference. This we initiated when we had a lot of patients on ECMO during COVID.
So yeah,
And
my experience has been my experience is very similar to what Daphne says. In those patients who've gone into nutrition related sarcopenia, not age related sarcopenia, there seems to be some kind of role of creatine in these particular patients at dose of 1.5 to 2 grams per day. A simple molecule doesn't cause major issues. Something that probably we'll watch this space, and probably ISPEN will come up with the first guideline on this too, on creatine, because it's something that's that we can use to mitigate sarcopenia. So there's another question that comes. So that has come in the chat box, which actually says, so I'll address this to Chitra. Chitra, you did talk about putting up all these various macronutrients. So there's someone who's asking a question about magnesium. Does magnesium play a role here? Do you need to supplement magnesium, or is it enough that the recommended RDA is already there in the particular, the supplement that you're giving? Do you require to supplement magnesium on a routine basis? That's the question that comes in.
Definitely no. Only patients need to be given only the recommended amounts. As I told earlier, overdoses of any of these nutrients is not going to help in any way, particularly in preventing sarcopenia.
Yeah. All right. And Khalid, among the protein that they want, they're looking at soya, they're looking at whey, casein based, or peptide based, and I don't know what not new things have come in, SMOF, and I don't know. So what is blended, and what is the protein that you would probably give? Is it going to be whey? Is it going to be casein? Is it going to be peptide, or is it going to be ultra hydrolyzed whey? What are you going to give? What are you going to give?
So I'll just touch upon the previous one or two questions first about vitamin D. I think vitamin D, there is lots of association with all the diseases, but treatment, I don't think it's going to cause any difference as of now, because patient is having deficiency for a long time. He's having chronic vitamin D deficiency, and supplementing that in the ICU is not going to solve your problems. Same is with magnesium. We'll treat with magnesium only in patients who are having hypomagnesemia. Otherwise, supplementation, whatever we are giving, that is more than enough. We don't have to give extra doses of magnesium. Now, coming to your point as to which type of protein you want to give, I don't think we want our patients to become bodybuilders immediately. So this protein, which protein is important for body? If you are in those elite group of bodybuilders, in the ICU, it does not matter which protein we give him, as long as we are giving him adequate amount of protein. So it doesn't matter whether we are giving him whey protein or isolate, or we are giving him soya. Whatever is tolerable to that patient and whatever we can give him adequate doses, I think that should be what we should focus on, rather than what is the type. Yeah, Dr.
Right.
Sanjeev.
So, Daphne, do you have any other view on this? What Khalid says is the type of protein doesn't make a difference as long as you are in critically ill situation. So, do you think that there is something different that you are thinking, or Hemamali, anyone who wants to answer this question for that matter?
there are studies which say whey protein is better. It has a better impact on outcome when we talk about soy or casein. So any protein, most of the supplements what we get, formula feeds, predominantly they are whey protein. Maybe add on, they might have a little bit of casein, and some of them have a combination of protein. But in general, if you take, predominantly it is whey protein which comes to us. So, that way it is quite acceptable, well tolerated among patients, and we do have a good outcome also.
Hemamali, do you have something to add on to this on the choice of protein? Is there something that you would do differently, or is it very similar to what people have mentioned, or the
Or
co-panelists have mentioned?
unless they are vegan people, patients,
Okay,
where
okay.
whey protein they do not like or they do not want, then we go for vegetarian plant-based protein, which is
Yeah.
also available now.
So Chittaranjan had asked a question talking about TheraBand exercises. Yeah, so this is one of the few exercises that really can be done as resistance-based exercises on a bedbound patient. TheraBand exercises are something that can be done on bedbound, and we know from data that against resistance, that is, TheraBand works against resistance, the rehabilitation potential and improvement in sarcopenia is very high when coupled with one of the designer proteins like HMB or creatine for that matter. So yes, TheraBand exercise is something you'd like to do. Anything lifting up against gravity is something which includes bench presses, which we see patients who are have the capacity to lift the weight. Even if 1 kilo he can lift against the bed, it will make a big difference in the rehabilitation procedure. So now I'm you will not even understand that we've finished an hour of this entire discussion. We've been on this discussion for the last 1 hour, and I didn't even realize that we finished an hour on this discussion. It's been a very great discussion. What I learned from this discussion is the fact that diagnosing sarcopenia is definitely a task. It is not easy to diagnose sarcopenia. The existing tools that we have to actually talk about physical strength, muscle mass, and physical function are not adequate enough to actually diagnose sarcopenia, at least in the average intensive care unit in the country. Um, we also heard from everyone that we shouldn't really be going very high on the amount of calories and proteins. We should start slow, and we should not be really trying to push this in. Yes, we don't want to upset this particular patient, especially thinking of refeeding syndrome and things like switching off autophagy and insulin resistance. So these are things that we don't want to get to. I also understood from you that the addition of designer proteins like HMB and probably using proteins, maybe using proteins like whey is something that might make a big difference for sarcopenic patients. I understood from Khalid, Chitra, and everyone that we need to move these patients, that getting out of the bed is very, very essential, provided that we can take care that there is no kind of problems that would come or side effects or kind of complications that would arise as a result of mobilization. And I think if we all work together to ensure that we adequately feed them after day 7, day 8 onwards, I think sarcopenia can be mitigated from the talk over here. So one line from Daphne on, we're going to end the webinar now, and I need one line from each one of y'all on sarcopenia for the audience that is over here. Just one line. Okay, so let me have one line from from Khalid first. So Khalid, let's starting from you. One line on sarcopenia that you'd like to advise everybody here.
I think with our patients, we should have a default setting that every patient who comes to the ICU who's critically ill, apart from his regular treatment for the disease that he has, we should be looking at whether is he qualifying to have sarcopenia diagnosis and will it affect his outcome. Once we get that in our mind, I think we'll start doing all the other things that we have discussed.
Yeah, so the first thing is picking up that patient is what I understand. Picking up that patient of sarcopenia, that is very important point that he's made. Picking up sarcopenia is very, very important. Dr. Himamani, is there one line that you'd like to tell everybody listening to us? Dr. Himamani, are you there?
She's not there.
Okay, so let's go to Dr. Chitra. Chitra, tell us one line on sarcopenia that you'd like to tell everyone.
While we are talking about treatment of sarcopenia, I would like to emphasize upon prehabilitation nutrition. So this really helps in the prevention of sarcopenia. So for those who may not know about prehab nutrition, this is usually given 7 to 10 days prior to the hospitalization. So patients who are going in for major surgeries or treatments, cancer treatments like radiation or chemotherapy or immunotherapy, can go in for prehab nutrition. Here, nutritional optimization is done. This is nothing but adequate proteins given with the right macros and micronutrients.
Thank you very much. Daphne, since this entire thing is a Chennai thing, you are given the honor to complete this webinar with your last parting statement. Daphne.
Okay, so when we talk about critical illness, you have to be early in everything. Early screening of sarcopenia, early initiation of nutrition, and early mobilization. Nutrition and early mobilization, those two will help in mitigating or arresting sarcopenia.
So thank you to all the panelists, and thank you to whoever's come in for this particular webinar. We will have much more of these, and we would love to have all of you again on a panel. It's great learning today, and from here, from all of us from ISPEN. Again, a congratulations to those 4 candidates who've joined the fellowship in critical care nutrition, and we will see you all in Pune in November. Khalid will be there for us over there at that
Yes,
time.
definitely. Yes, I welcome all of you there. Yeah.
That's awesome.
Welcome. Thank you. So we call this webinar end. Thank you very much, everyone. Thank you very
Yeah,
much.
thank you.
Thank you.
Yeah.